Thanks, David. And that was a great debate that we just heard. I wasn't given a debate partner, so I think I'm going to end up debating myself. I'm going to talk about both the promise and the pitfalls of molecular testing the diagnosis of MDS. These are my disclosures. So what I'll go through is first talk about what I think ideal features of a diagnostic mutation might be. What are the kinds of things that we would be looking for when looking for these markers that might help us make a diagnosis of MDS. And then I'll talk about why these things might be useful, why we might want them to help us make these diagnoses that can be challenging. But I'll spend most of the time talking about why we haven't yet gotten to this point and what is actually standing in our way, what those obstacles are that make molecular diagnostics for MDS rather challenging. And I'll finish by talking about how I think we can take what we know now and actually apply it clinically, what the way forward might be. So let me start with just the general concept of a diagnostic mutation. And we have great examples of these in other myeloid disorders. So one of the features that I want to point out is that in myeloproliferative neoplasms, we've totally changed how we look at these disorders by understanding the molecular genetics. And in fact, for any given myeloproliferative neoplasm, there is a gene or set of genes that can help us make the diagnosis. And they also tell us other things about potential response to therapy or prognosis, but they can actually be used as part of the diagnostic criteria. And in fact, for some of these, they might be even sufficient to make the diagnosis in certain clinical settings. Now, we do something similar in AML as well, where we have AML subtypes that are defined by their molecular genetic features. We have the MLL rearranged AMLs, we have the core binding factor leukemias, the retinoic acid receptor rearranged AMLs, and even within those groups, we have subtypes that are defined by their mutations, like the KIT mutant core binding factor leukemias. So the hope is that having done this in myeloproliferative neoplasms and having a precedent for having done this in AML for some time, that we might be able to do something similar in MDS, where we actually define the disease by its genetic features and can go away a little bit from depending on morphology and other more subjective measures. Now, there are a lot of genes that are mutated in MDS that might give us the ability to do that. And these are two large studies that looked at mutations in MDS. And you can see on the far left of these plots that there are genes that are frequently mutated in these diseases. But you can see that for the most part, most of the genes mutated in MDS are mutated infrequently. So there's no one mutation that is the overriding, say, MDS mutation, or even a pattern of genes that are mutated that define MDS. And that's going to be one of the major challenges that I talk about. So what kind of features do we want in a diagnostic mutation? One thing that would be helpful is if we're considering MDS to be disease C, is if we had one gene that was mutated in the majority of cases. That way, if you didn't find that mutation, then you could suggest that the disease might be something else and not MDS. Now, this is what's true for myeloproliferative neoplasms. The red might be JAK2, for example, and disease C might be polycythemia vera, where if you don't have a JAK2 mutation in a polycythemic patient, you start thinking about secondary causes of polycythemia. Even though JAK2 can be mutated in other disorders, its presence or absence is really informative for that disease. Now, we don't quite have something like that for MDS. The other scenario where a mutation might be really helpful is if it's very specific for the disease. So if you have a gene that maybe isn't mutated in the majority of your cases, like most of the genes in MDS, but isn't mutated anywhere else at all, then identifying that mutation is very helpful from a diagnostic standpoint. So this example might be a MPL mutation in essential thrombocythemia, which is very rare in diseases other than essential thrombocythemia. Even though it doesn't constitute the majority of cases of that disorder, if you find it in a patient with an elevated platelet count, you're feeling much more comfortable that that's truly what they have. So why might this be useful in MDS? Well, one of the challenges that we have in this disorder is actually discerning it from other related disorders. Things like myeloproliferative neoplasms, where we even have a category for the overlap of these diseases, other clonal diseases like PNH, and even other non-myeloid diseases like LGL that can mimic MDS. And if we have patients in whom we have some diagnostic uncertainty, sometimes that uncertainty isn't whether or not they have a problem, it's which problem exactly do they have. But most of the time that I spend in clinic trying to diagnose MDS isn't necessarily trying to identify whether they have one of these, it's trying to identify whether they have one of the more benign causes of cytopenias that can mimic MDS. And if I had a clonal marker, I might be able to put patients in one category or another and feel much more comfortable about my diagnosis. Ideally, if I had a clonal marker, I'd love to be able to simply exclude everything on the left side of the slide, all the autoimmune disorders, the potential medications, the vitamin and mineral deficiencies that might mimic MDS and be much more focused on what I consider to be the clonal causes of their disorder. So that's the hope. I'll tell you why that doesn't quite work in just a bit. Now, I mentioned that it worked well for the myeloproliferative neoplasms, and it does. And I think part of the reason for that is that the biology of these disorders is different. These are a proliferative disorder, and they have mutations in genes that drive that proliferation, and there's only certain numbers of ways that that can happen. So the list of genes that are helpful in the diagnostic context is much more limited, and they're much more tightly associated with the patient's phenotype. So here I showed you the examples that I mentioned earlier. But for MDS, the biology is that we disrupt erythroid differentiation or hematopoietic differentiation, and there are many, many ways to do that. So there isn't, again, one overriding pathway or one overriding mutated gene that drives that process, and we don't really find a single signature that we can associate with MDS. In fact, many of the genes that are mutated in MDS can also be mutated in other myeloid disorders. Now that said, there is a column in the WHO guidelines as they stand today that tells us that we can use certain chromosomal abnormalities as presumptive evidence of MDS in the absence of morphologic criteria. And these are some of the common things you're familiar with, monosomy 7, deletion 5q, and so on. If these are present and the person has cytopenias but doesn't have enough dysplasia, they still get labeled to have MDS. What we were hoping is that we might identify mutations that could fill in a third column in this table that we might be able to use as presumptive evidence of the disease. Now, please don't write this down because I just made these up. These are things that I would hope might work, but in actuality, they don't. And why is that? Let's take a closer look at the list of chromosomal abnormalities. There are a few that are missing from there. So, for example, there's no del20q or trisomy 8. And the reason that they're not included, in part, is because they're not really specific enough for MDS. These are chromosomal abnormalities that we frequently see in other disorders, be they AML or myeloproliferative neoplasms. So if they're present, they might indicate that the person has clonal hematopoiesis, but they don't, and by themselves, give you that diagnosis. Now, we also don't see loss of chromosome Y. And we know that this is a relatively common event, and the reason that it's not listed in this diagnostic criteria is that it can occur in individuals who don't actually have a hematologic disorder, and we know that this can be an age-related phenomenon. So more in that in a minute. So are the mutations more like the things that are in the table, or are they more like the things that were excluded from the table? And the answer is the latter, and I'll give you some examples of that. So this comes with the pitfalls of molecular diagnosis. Before I even get into the challenges of whether mutations are useful or not, let me start with the challenges of interpreting mutations. That I don't know if you guys have experience with genetic testing, but we get this all the time where you send out a genetic test and you get the data back from the company or the facility that did the sequencing, and there's a list of variants of uncertain significance. And sometimes those are the only things that are listed on that report. So what do you do with that? We have some genes like SF3B1, for example, that have some really well-known hotspots that are frequently mutated. And if you find a mutation in one of those, great. I would say that you're done. You know that that person truly has a somatic mutation in that gene. And this is data from Cosmic, and you can see that, let's see if I can get the pointer to work, that these are the commonly mutated genes. There's a whole slew of genes that are mutated, in single instances all across this gene. What happens if it's one of those that comes back in your report? How do you interpret that? Do you even know if that's a somatic mutation? So that's one challenge that we see all the time. In ASXL1, that's highlighted as well. There are certain mutations that are really stereotypic for ASXL1, things like frameshift mutations or nonsense mutations shown in orange. But often we get missense mutations that are scattered anywhere along the length of the gene, and these can also be very difficult to interpret. So we're still dealing with that difficulty that I think we don't have with cytogenetic abnormalities, that we don't quite know how to interpret these variants of uncertain significance that come up frequently. But let's say you do find a somatic mutation. What do you do with that? Well, one of the challenges is that we need to know what the background rate of somatic mutations is. And I think that prior to these studies that I'm showing on this slide here, we assumed that that background rate was relatively small. And it turns out that that's not the case at all. These are studies that took individuals that did not have hematologic malignancies or other hematologic disorders or even cytopenias and sequenced them for various reasons. And then some very astute investigators from different groups scrutinized this data and found that these individuals actually did have somatic mutations. And this is data from two of the studies that were published together. And the genes that are mutated are the exact same genes that are seen mutated in MDS. DNMT3A, ASXL1, TET2, even JAK2, even P53 that we typically associate with a terrible prognosis in these disorders can be mutated in individuals that are simply living their life without any hematologic disorder. The striking thing is the incidence, or I would say the prevalence at which this occurs. That as individuals age, if you look at 70-year-olds to 75-year-olds, which is the typical age for patients with MDS, the incidence of these mutations that indicate clonal hematopoiesis is 10% or maybe even 15%, so it's quite high. Orders of magnitude greater than the prevalence of things like MDS and other myeloid malignancies in this age group. Now, something to know about these mutations is that they're not extremely abundant. That is, they're not responsible for the bulk of hematopoiesis in these normal individuals. In fact, in most of the persons in which this was identified, they accounted for about 20% of the cells in the peripheral blood. So this is a little bit different than thinking of something that is completely clonal and has totally replaced hematopoiesis. And these individuals do have a higher risk of developing a clonal malignancy. In fact, the relative risk is actually quite high. It can range from 10 to 50-fold, but in actuality, the absolute risk is still very, very small, meaning that the majority of individuals who have clonal hematopoiesis will not go on to develop a hematologic disorder. So this has been termed clonal hematopoiesis of indeterminate potential, or CH-I.P, mostly because we don't necessarily know if there are particular mutations or particular features that make one more likely to progress at this point, but we know that most persons will not progress. Now, one feature that was interesting was that if you look at those individuals that did develop a hematologic cancer, their mutations tended to be more abundant. They tended to be responsible for a greater proportion of their total hematopoiesis. So keep that in mind as we go forward. Now, in actuality, you are not going to be sequencing people with normal blood counts. The people who come to you are going to be cytopenic, and those are the folks that you're going to suspect MDS in, and that you're going to want to make the diagnosis, and you're going to send those folks for sequencing. So we did a study to address whether the mutation spectrum is different in this population. This was a prospective study that took patients whose physician thought they might have MDS because of their cytopenias and sent them for a bone marrow study. We did a traditional diagnostic workup that included morphology, flow cytometry, karyotype analysis, and so on. And of the 144 patients that we enrolled in the study, only 24 had a frank diagnosis of MDS. There were a few others that were excluded for things like CLL or other things. But of the ones that were included, only 24 had MDS. There were another 21 that had some evidence of MDS. That is, they had some dysplasia, but it didn't meet that 10% threshold that's required to make the diagnosis. And then the vast majority, 99 in this cohort, had no evidence of dysplasia whatsoever in their bone marrow, and these patients were essentially returned as saying no evidence of MDS. We then took their bone marrow samples and we subjected them to next-generation sequencing in this panel of genes here with some typical myeloid genes. And we could identify mutations in most of the MDS patients, in 70% of them. But we could also identify mutations in 60% of these patients that had some degree of dysplasia. So again, much higher than that 10% rate that I quoted you for 70-year-olds who don't have hematologic disorders. But even in those patients that had no dysplasia whatsoever, we could identify mutations in 20% of those. If we put that together with the few patients that also had chromosomal abnormalities, we can find that almost every MDS patient had evidence of clonality. 70% of those patients with some dysplasia had evidence of clonality, and 25 or 27% of patients that had no evidence of dysplasia whatsoever had evidence of clonality. So on average, the patients that weren't diagnosed with MDS, about 40% of them could be found to have either a mutation or a chromosomal abnormality that was acquired. So this group of patients that did not meet the diagnostic criteria for MDS, we label as having ICUS, or idiopathic cytopenias of undetermined significance. And this is a relatively heterogeneous group, but we're hoping that by identifying the subset that have clonal markers, these patients that have clonal cytopenias of undetermined significance, that we might be identifying the subset that are at greater risk of progression to MDS, even if we don't call them that today. I'll give you more evidence of that in a second. So these are the genes that we found mutated in our patients, the same genes that are found in MDS, SF3B1 being slightly more common in MDS, and I'll show you another example of that. But the interesting thing is that in our cytopenic patients in whom we found mutations, the abundance of these mutations was high. It was comparable to that in the MDS group, in fact, and it was much higher than that 20% that I mentioned in patients who have CH-I.P or no hematologic disorder. We then supplemented that by doing a retrospective analysis, looking at 250 patients that were already diagnosed as either having ICUS or MDS, and compared them, and found again that about 40% could be identified as having a clonal marker. And the spectrum of mutations is very similar, and in this case it was a little bit more prominent that those patients who had MDS were more likely to have SF3B1 mutations. And we think we understand this. SF3B1 mutations are so tightly associated with ring sideroblasts, a feature that pathologists can pick up relatively easily, that SF3B1 mutant patients were more likely to be diagnosed as MDS. In fact, when we looked back, if you ignored ring sideroblast as a diagnostic criterion, most of the patients who had SF3B1 mutations would have been considered to have ICUS because they didn't have enough dysplasia in other cell lines to meet the criteria. Again, in this retrospective study, the abundance of mutations in patients, even patients that had no dysplasia whatsoever, was high, and it was comparable to that of the patients in the MDS group. We then took a closer look at what distinguished patients with MDS versus patients with clonal cytopenias versus those patients that had no evidence of clonality. And there wasn't too much that separated them. There was a little bit of a female predominance in patients who had no evidence of clonality. But the age of patients without clonality was about a decade younger, not surprising given that these mutations are age-associated. And again, not surprising, the degree of anemia was slightly greater in those individuals that had frank MDS. So patients with more dysplasia were more likely to have greater cytopenias, at least with regard to hemoglobin. That wasn't true for ANC or platelet count. When we published that study, a companion study was published with it that started to answer a really important question. What happens to these individuals that have clonal cytopenias in the long term? So this study didn't quite get at that, but what it did is it took 69 individuals that had a non-diagnostic bone marrow, all of whom subsequently went on to develop a frank hematologic malignancy. In this case, 39 of them developed either AML or refractory anemia with excess blasts, and 30 developed refractory anemia or CMD. And you can see there's quite a long latency between these two time points, so it wasn't something that happened overnight. They went back and sequenced that initial non-diagnostic bone marrow, and they found strikingly that 91% had a mutation. So almost every patient that had one of these non-diagnostic bone marrows that subsequently went on to develop a frank malignancy had clonal hematopoiesis at that early time point. And in fact, only 43% of them actually went on to develop a new mutation, meaning most of the mutations that were found in the eventual diagnostic sample were already present in that non-diagnostic sample done, in most cases, over a year or a year and a half earlier. So this suggests that having clonality and that having a high burden of mutation is a significant risk factor for subsequent progression. If we put that all on a table where we compare CH.I.P, these are essentially unselected individuals who may not have a hematologic disorder, at most you typically find one mutation, and that mutation is not very abundant. Whereas in patients who are examined at diagnosis with cytopenias, the mutation burden is a little bit higher, and the abundance of these mutations is much higher in each patient. And if you focus on those cytopenic patients who actually went on to develop a frank hematologic malignancy, the mutation burden is even higher. Those patients have a mean of 2 mutations per patient, and the allele burden is very high as well. And when you compare that to people with frank MDS, the mutation burden isn't that much higher. It's only 2.6 when you look at a panel of genes similar in size. And again, those patients are almost typically totally clonal. But if you look at cytopenic patients in general, at least what we learned from our study was that the majority will not have MDS. The majority will fit into one of these ICUS or CCUS categories. So we have a lot of patients that are really left in this diagnostic ambiguity zone. What we need now is a better understanding of which mutations predict eventual progression. But we can start to take some information out of this that says maybe number of mutations matter and maybe degree of clonality matters. So what do we do going forward? Well, one thing we can do is cheat. That is, if our mutations really don't fit neatly into our existing diagnostic categories, we can just change our diagnostic categories and make sure that our mutations define them instead. So can we do that? Well, we've done that in the past. We have taken patients with del(5q) MDS and said that these are really their own subtype of MDS. This is their own diagnostic group, and it made sense to do this. These patients are more homogeneous. They're more like each other, particularly with regard to their overall survival and their response to lenalidomide, as we just heard. Is there any genetic analog of this, at least at the gene level? And it turns out that there is, that patients who have refractory anemia with ring sideroblasts do substantially better if they have an SF3B1 mutation. If they don't, they do substantially worse. And in fact, even if patients who fall outside of the traditional diagnostic criteria of MDS, those patients that maybe only have 5 or 10% ring sideroblasts, if they have an SF3B1 mutation, they behave much like their counterparts who have more than 15% ring sideroblasts. This was shown in a recent paper by Luca Malcavati and his group. So the WHO has actually took this to heart, and in the next iteration of their guidelines, which will be published in a few months, they actually now include a category that expands the umbrella of MDS to include patients who are SF3B1 mutant and only have 5% ring sideroblasts. So they're really just dipping their toe in the water of molecular diagnostics, but they are finally including one genetic mutation in this system, and that may drive the impetus for actually getting sequencing on patients as part of a standard of care process. although they only include one gene. I'll give you some examples of why it's really important to look at a lot of genes if you're thinking about using molecular diagnostics. So the other way that we could redefine this is we could change our disease categories entirely. We could say, well, higher risk MDS really has a lot more in common with AML, so why don't we just call those oligoblastic leukemias when we see them in patients with dysplasia? And patients who have clonal cytopenias, whether or not they have 10% dysplasia may not matter, so why don't we just lump them together and call those patients as having clonal cytopenias? And we're drawing our lines in different places now. And the advantage of that is you can use more objective criteria. Cytopenias are relatively objective. The presence or absence of a mutation is relatively objective, and you're not worried about whether a person has 10% dysplasia anymore. So is there any evidence for doing this? Well, there is a study that I think hasn't gotten as much attention as it deserved. This is another study by Luca Malcavati where they actually took a large number of MDS patients, considered their genetic features and their clinical features, and did some agnostic clustering to see which ones grouped together based on these features. And they found 4 groups. The first was patients with excess blasts were clearly their own group, particularly with regard to prognosis. But in those patients that did not have excess blasts, you could divide MDS patients into 3 categories. Those on the left that have an SF3B1 mutation, those on the right that have mutations in other splicing factors and epigenetic modifiers like TET2 and DNMT3A or ASXL1, and then the remainder in the middle that didn't have mutations in any of those genes that I just mentioned. The ones on the right also had a high proportion of patients who had RCMD, so patients that were more likely to have multilineage dysplasia. What they found was that simply using these categories, and no clinical variables, no age, no blast count, you could put patients into one of 4 risk groups. And they had significantly meaningful differences in overall survival and similar meaningful differences in AML progression. With the patients who had none of the mutations that I mentioned doing the best, followed by the SF3B1 mutant patients, and then the patients doing the worst were those with excess blasts. So it might lead to something, again, totally that I made up, but that might allow us to categorize patients based on molecular features in the future. Maybe we're separating our SF3B1 patients as patients who have a better prognosis and less likelihood of progression to AML. Maybe we're breaking out those patients that have P53 mutations. I didn't mention this, but these patients often have few mutations in other genes and tend to have a uniformly bad prognosis. We're separating patients with excess blasts as maybe the oligoblastic leukemia subtype. We're keeping the del(5q) category, and then we consider including those patients that have clonal cytopenias without a significant amount of dysplasia, even if they might do better, but at least putting them under the same umbrella as patients who might need closer observation or may even need treatment for cytopenias in ways that we do similar to patients with low-risk MDS. So as I close on my last slide, I want to talk about why I think using a large panel of genes is important. I'll give you some examples of how mutations can be completely diagnostic when you suspect a patient might have MDS. So this is an anecdotal story. A patient, 73-year-old, 18-month history of mild but progressive anemia. We've ruled out most of the secondary causes that we think might mimic this disorder. And by the time he sees me, he's already had 3 bone marrow biopsies, all of which have been non-diagnostic. And he's even had a 5-gene MDS panel that had no mutations identified on it. So we sent a broader gene panel, and we came back with a mutation in STAT3. So this is not an MDS gene. This is a gene that's frequently mutated in patients who have LGL. And we went back and did careful flow cytometry, including NK markers, and found that he had NK cell LGL. And this is very good news for him. He doesn't have MDS. This is something that would be treated in a completely different way, and he now has a diagnosis and doesn't need monthly bone marrow biopsies anymore. Second case was a 64-year-old man, 3-year history of mild but progressive pancytopenia, benign causes largely excluded. Had a bone marrow biopsy a year before he saw me. That was, again, not totally diagnostic, but at the end, the pathologist said, consistent with lower risk MDS, clinical correlation is advised. A year later, he has progressive cytopenias, and we do a repeat biopsy. And at this time, we get the diagnosis based on the biopsy, but we also get a genetic profile back, and he has a BRAF mutation, which is the hallmark of hairy cell leukemia. And while we didn't need it to make the diagnosis by the time that he saw me, I bet if we had done that sequencing a year earlier, we would have found that BRAF mutation, and we would have been thinking very hard about that diagnosis instead of equivocating about whether or not he had MDS. So I'm an advocate of having gene panels that are broad and inclusive of all the myeloid malignancy genes, but also broad enough to include mimics of MDS or even congenital syndromes that might contribute to MDS, so we can identify those at the time of diagnosis. So to summarize, somatic mutations in MDS are not yet frequent enough in the disease, or no single mutation is frequent enough in the disease, or specific enough to define it at the moment. And the high incidence of C.H.I.P makes it difficult to say that a mutation is responsible for a patient's cytopenias in the absence of other factors. but that these patients who do have clonal cytopenias are worth following, that these are probably the patients that are at highest risk of progressing. And specific patterns of mutations may eventually be diagnostic. For example, if a patient has 3 mutations, that might be outrightly considered to be MDS. And there are certain mutations that will be considered in the upcoming guidelines, like SF3B1, and they may have greater utility in classification after diagnosis. So with that, I'll end. Thank you.